did not approve it yet to be used with the GLP-1 yet, but there are actually small studies that shows that if you combine GLP-1, which has a good weight reduction effect, with the SGL2, which has a good weight reduction effect, yes, you can lose more weight. I think they will emphasize this point by almost 2016 by the ADA. If you look here, you can see that the ACE guideline use it even from the beginning of the diagnosis of diabetes. They don't believe metformin is the initial therapy on those group. Canadian guidelines just released in 2015, around 5 or 4 months ago, and they added SGL2 inhibitors. I know, sorry, it's very small, but I promise you I can provide you with a slide. That they just introduced that as a second line after metformin therapy. And if you look at the available drugs, what's available here in Kuwait is actually at the time being is the DABA, which is Foxija, and the Kana, which is the Invokana, which are actually available in Kuwait, and they're actually available in the private sector. And I think soon they will be introduced to the Ministry of Health. So you guys are going to be exposed to those new medication. And of course, Dr. Mohammed Hassanin was mentioning about EMBA, which is not yet available. I think they are in the process of registration in Kuwait. And those are the 3 available medicine will be here in Kuwait to be used. This is the thing, I'm just going to show you, what do you think is the A1C reduction of the new class? Is it 0.51, 1.5, 2%? What do you think is the right answer? 0.5? 0.1? 0.2? Mafi 0.2, 2%. 2%, 1.5. Anyway, if you look at the literature, different literature would tell you that the A1C reduction of an SGL2 inhibitor is between 0.5 to 1.5. But if you look at decent guidelines, they will tell you it's around 0.7%, around 0.1, around 1%. So if you look here, and the DDB4 inhibitor is somewhere between 0.4 and 0.7, but you could see that the highest still is the insulin and the sulfonylurea and metformin with a more of 2% of A1C reduction. So very important point, because it doesn't work on the pancreas, the SGL2 inhibitors, you could actually use it independent of insulin, meaning that it doesn't really require the pancreas to function because it's actually working through the kidney. And therefore, the principle of this medication that you could actually use it at any stage in the natural history of diabetic condition, any stage, because it doesn't really depend on the pancreas. But I have to put a couple of lines under this statement because of what I'm going to be talking about. Remember when I told you about the sodium, which I told you is very important. So sodium retention and volume expansion may be induced by both insulin and hyperglycemia-induced increase in filtered glucose load. This means if you have a patient who actually, there are actually studies, if you have a patient who you did not start them on insulin, and you start insulin, their blood pressure goes up just by starting insulin therapy. I'm not saying insulin is not good, but I'm just saying what's happened. So if you have an excess of glucose, which is filtered through the kidney, it drags with it what? Sodium. So that's why the blood pressure goes down, because you're actually dragging out the sodium with it. So the excess filtered glucose is reabsorbed, and the salt loading tend to rise the blood pressure. So the effect can be reserved by salt restriction, and then so the sodium is being reabsorbed in parallel with the glucose. So SGL2 inhibitors reduce hyperglycemia and via increased glucoseuria. And this is, I find it very useful slide, because it shows you the most important 3 factors of this group and what can it do with your patient. So it increases glucose excretion, so this will lower down the glycemia and then eventually will lead to decrease in A1C. Of course, you lose calories. You lose between around 300 calories, so this will lead to weight loss. And because of increased sodium excretion, which I showed you, this will lead in decrease in blood pressure. Is this reduction of blood pressure is good? Showed that by the MBAB, which I'm not going to be talking about here, that that medicine has all-cause mortality reduction by 30% related to cardiovascular disease. So, perspective on SGLT2 inhibition, potential advantage, insulin independent, weight loss, low risk of hypoglycemia, blood pressure lowering effect. Concern, polyuria, electrolyte disturbance. So it's very important, whenever you start your patient on this medication, I usually ask them to come back because their their potassium might go up a little bit, so I actually ask them to come back in 3 weeks to recheck their electrolytes. There is an increased risk of mycotic infection in that region, and I usually tell them they have to wash very thoroughly after they go to urinate. And there was some question mark about risk of malignancies. This is the last two important points I'm going to be talking about. I don't know if you guys know about SGLT2 inhibitors and the risk of developing DKAs. And it's an interesting terminology. We know about it from before because we see it in pregnant lady. It's called euglycemic diabetic ketoacidosis. And they found, and there was an FDA warning regarding this group in terms of developing diabetic ketoacidosis. And the thing about why those patients actually develop diabetic ketoacidosis, all of them are actually case reports. And going through the history and through the cases, many of them was actually type 1. So the medicine was actually used in type 1 patient, which is not indicated for this class of medication. You should not use, none of the company will advise to use in type 1 patient, but many of those cases actually in type 1 patients. Very important, you have to choose the right patient. Who are actually the right patient to use those medication with? Why they develop diabetic ketoacidosis, I know it's not very clear. Victor, really, that telephonic? It's okay. That's okay. So what happened is that those SGLT2 inhibitors lower down glucose level. So by lowering down glucose level, you lower down insulin level. If you lower down insulin level, your body will require a source of energy. So how diabetic ketoacidosis happen in those patients? So I just want you to follow me carefully. So this patient have an insulin. So the insulin level goes down. And because you require insulin to utilize glucose. But if you don't have enough amount of insulin, the body will try to find out another source of energy. So what will happen that the fat cells, which is lipolysis, will increase. This lipolysis will increase, will lead to release of free fatty acid, beta oxidation, ketone production, and then acidosis, and diabetic ketoacidosis. Okay? And the other reason why they cause, for unknown reason, they increase also glucagon level. That's why they don't cause hypoglycemia. And then because if you're increasing the glucagon, then there will be more acetylcholine, and then eventually more ketones production. So you get the point? Less insulin, you cannot utilize glucose. Then the body will try to find another source. The other source is the lipolysis. When you use the lipid, what will happen? There will be increase in beta oxidation, and of course the body will produce ketones. And then the patient will develop diabetic ketoacidosis. And the peculiar about diabetic ketoacidosis and SGLT2 inhibitors, they're actually euglycemic, means that the sugar is not high. So that might be confusing. So any patient come with metabolic acidosis to the casualty, type 2 or type 1, and you know that they started, is not necessarily that sugar goes up. The other important factor, which is very important for us next year, because this medicine will be introduced at the Ministry of Health, is the SGLT2 inhibitor use in Ramadan. Because I told you that those medications might actually induce polyuria. There might be volume repletion. There might be a volume issue with those patients. So what would you do with your patients? So there is actually no consensus regarding the use of SGLT2 inhibitors during Ramadan. No consensus. So far, you would tell me what would you do with your patients. So very important points to understand. Very limited study, or actually there are no studies yet. We know that they have a low risk of hypoglycemia, but they might actually cause volume repletion. And we are concerned with the diuresis effect and hypovolemia with those medications. And I usually don't start a new medication on the month of Ramadan or a couple of days before the month of Ramadan. I usually started whether 2 weeks, 4 weeks before the month of Ramadan. So I had a couple of patients actually who used this medicine last Ramadan. So I'll tell you what happened with them. I don't have the whole data of them, but I'll tell you what happened with them so far. So I had 10 patients, different SGLT2 inhibitors during Ramadan. All of them started before Ramadan, and actually started them 2 to 3 months before the month of Ramadan. None had to break their fast, but what I actually told them, I instructed them very carefully to limit their physical activity during the day. We're waiting for more data about the use of this class of drugs with Ramadan, the month of Ramadan, and inshallah by not this Ramadan, maybe the next Ramadan, we'll be having more data regarding this issue. And that's it. Thank you very much. Okay, I don't know where is Dr. Walid, but I'm open for any questions. Dr.
So we'll open the floor for questions. Any more questions? Okay. Thank you, Dr. Talal. We'll take a break. Before the break في سحب. راح يكون الحين في سحب وراح يكون في سحب بعد المحاضرة النهائية بعد. So we have 2 more سحب, 4 more presents. Thank you, Dr. Talal, for your excellent lecture. Thank you. So we'll bring the people to do the سحب. Dr. Mohammed Suwaid. ماشي. Next. دكتور عماد الهادي. دكتور عماد. مشى. يلا دكتور عماد. يلا. ذي. شنو؟ دكتور حسين أسرهان أو السرحان. دكتور حسين ما في. خلوني أنا أسحب هالمرة. يا كل يقولون يبون فيميل، ما أدري ليش يبون فيميل. دكتور محمد القحطاني. رجال قوامون على النساء. اوكي. طلعت فيميل. يلا. دكتورة مها العازمي. ان شاء الله موجودة. راحت؟ يلا مو رزقها. ان شاء الله يكون بعد فيميل. Dr. Gul? Yeah, okay, good. So, this is going to be for your wife because we had 1 female. You have a wife? 2? Okay. Okay, نطلع بريك. Okay, نطلع بريك عشان نصلي المغرب وصلاة ونرجع وبعدين في سحب and my lecture, the last lecture. And thank you for staying.